What is up, everybody? Welcome to the Gestalt Education Show. Today's episode is a very special one that includes Dr. Anthony Romeo. So Dr. Romeo is the guy when it comes to repairing Latissimus Dorsi tears in Major League Baseball players, and someone that Brett and I have been really wanting to sit down with. And so we have to give a huge shout out to Adam and Julia Bruni and for making this happen and for sitting down with us. It was an absolute treat. We get to spend, I don't even know, 3-4 hours at Dr. Romeo's house. He introduced his family to us. They got us sushi. It was just an unbelievable experience. And so we only condensed this down to an hour. We didn't want to be too gracious with our time, even though he was giving us so much. And so Brett and I really didn't get a chance to kind of nail down some of the more like functional ways that we think that this problem can be addressed. And so we're going to sit down and just kind of like review everything that we talked about with Dr. Romeo in this episode, but then also kind of give our own take on this epidemic. And so stay tuned for that in the following weeks. Should be next week. But anyway, really enjoy this episode with Dr. Anthony Romeo. There's just amazing clinical pearls in there. Stay tuned. Today's episode of the Gestalt Education Show is brought to you by 3 of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them. So check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are in Hinsdale, Illinois at Casa de Romeo. And so we are so ecstatic. This has been kind of one of our white whales, someone that I know Brett has talked about a lot of times, especially when he's talking about baseball. But one thing I didn't know about Dr. Romeo, he's got bigger arms than Brett Winchester, which is hard to find. And so I'd be remiss if I didn't start the podcast by saying we found him. I mean, we found someone with bigger triceps than Brett Winchester. So congratulations. But anyway, so today's guest is Dr. Anthony Romeo. You may know him from his expertise in the throwing shoulder, especially in the lat repair. And so we're really going to dive deep into that. But then we also are flanked by 2 amazing individuals that made this happen, Adam and Julia Bruni. And so we thank you both very much. I can't wait to hear your perspective, Julia. And then Adam, we're back-to-back weekends, buddy. So this is exceptional. So anyway, let's kind of break down to it. So Brett, you've kind of talked, obviously, we're here in Chicago for a DNS baseball seminar. And so, we've kind of seen a resurgence or an uptick in this injury, which is the lat. And so can you kind of talk just to start us off about kind of your thoughts on it? And then let's kick it over to Dr. Romeo and kind of get what his thing is.
I think the question that, everyone is asking right now is this becomes like kind of the new problem in baseball is, what can we do to prevent the injury? So we know that we have the experts in the world that are fixing it. So like, what are the trends that we could be looking for and stuff that way we can hopefully prevent this injury. And I'll be curious to hear what Tony says about, big tendon injuries in the lower extremity. They're kind of like a death knell for our athletes. And I'm assuming in the upper extremity, it can be similar. So sometimes the best treatment would actually be hopefully to prevent the injury. And thank God we have people that are able to fix it. But then what are some of the things, is this a biomechanical thing? Is this a load thing? Is this a scapular dyskinesis thing? As time goes on, hopefully we'll be able to kind of pick some of the things, and that are predisposing the athlete to those injuries. So the first thing I'm just dying to ask you is, I know you're a great surgeon on a bunch of things. How did you get tight casted into the lat? I know the name Jake Peavy, but how did you even get this reputation of being the expert in the world at repairing torn lats?
In 2010, it was in the summer, and Jake was pitching, I believe it was the second inning, and he went to throw a pitch, and as soon as he finished the pitch, he reached over underneath his right throwing arm and grabbed essentially the back of his armpit and walked straight off the field. And a couple of things were remarkable. Number one, he was able to finish the pitch. So normally if you were to tear the ligament in your elbow as you're going through the throwing mechanism, you can't finish the pitch so the ball goes high and outside. So he was able to finish the pitch. So we knew that the injury happened at the very end, or the deceleration part of the throwing. And then I got a call later that evening from one of my partners who was covering and said, "Hey, have you ever seen something that like a lat tear or something. I mean, he's really painful in the back of his arm, in his armpit, but, I don't see anything else going on. He can move his arm. He's neurovascular intact. And I said, well, we see him, but it's pretty uncommon. And we'll get the MRI tomorrow and see what it shows. And sure enough, we got the MRI, and it demonstrated a complete avulsion of his latissimus tendon tear. His was what we call a grade 4. So 1 would be a strain to the muscle and tendon without any detachment. 2A is a partial detachment, less than 50%. 2B is a partial detachment, more than 50%. 3 is when it comes off, but it's less than 3 centimeters away. The thought process being that there are some intramuscular attachments that are holding in place, and a 4 is when it's all the way down. And Jake had a 4. You could actually reach into the back of his armpit and feel the lump in his side. So he's from Alabama, so he flew right down to see Dr. Jimmy Andrews. And Dr. Andrews took a look at it and said, well, Jake, we normally treat these non-operatively, but yours is so bad. And I've seen a number of players that have this, that have a hard time getting back. I think you should get it fixed. And Jake goes, okay, when do you want to do it? And he goes, well, I don't do it. You need to go back up to Chicago and have Romeo do it. He does that kind of stuff. And so that was literally what happened. Is it was a referral from Jimmy Andrews back to me. And he called me and said, hey, I want you to fix this. I don't really do these things. I know you have to do lat repairs and some lat transfers, some of the surgeries that you do, and I think you'd be much better at it. So I literally called my partner at that time, and we went down to the cadaver lab the night before his surgery, and we dissected out a cadaver to go over all the anatomy from the front of the shoulder to the back of the shoulder, because I was thinking, well, we don't do a lot of these in baseball players. This is a guy that's being paid $18 million a year. I better not mess this one up. And I also knew that 2 or 3 of my partners were going to be in the room, and I didn't want to get any flack from the peanut gallery while I was doing the case. So I felt very strongly I had to be the smartest guy in the room as best as possible. And sure enough, the next day we did the case, and the lat on the MRI seemed to be only about 3 centimeters away from its attachment. But so I made an anterior incision, and sure enough, I couldn't feel it at all. And so then I felt this side, you could easily feel the lump. And so I just made a longitudinal incision about 4 centimeters, and literally the tendon just dropped right out of the incision. And so I put the sutures in that, and then I passed it, tunneled it up through and back through the anterior incision, and we repaired it into place. And another interesting thing that happened at that time is we tried a bunch of different anchors, and the anchors that we normally use for rotator cuffs and other things weren't strong enough. They were breaking in his bone. And I tried to use even these types of anchors where you drill a hole and it has a button and it could spin, but it wouldn't spin inside of his bone. He's a young guy. He still has bone marrow in there. It wouldn't spin at all. So I finally came up with these types of anchors that are made by a company that actually they have absorbable sutures on, and I rethreaded it with non-absorbable sutures, and I used these anchors which we would never use today, but that's all I had, and I fixed the tendon, and it worked. So I can tell you the next day I called the company. Is that okay? That sound?
Oh, yeah.
Okay.
Yeah.
The next day I called the company and I said, we need to make new anchors. And I said, well, what do you need? I said, we need these buttons. He goes, we already have the buttons. I said, no. And I sent him a picture, and I did a 45-degree chamfer on the end. I said, if you put a 45-degree angle on these buttons, I think I'll be able to push it to the other side, and then it'll spin, and I'll be able to bring it back into place. And within 3 months, we released a kit for repair of these type of tendons. And because it's so rare, we actually called it the pec tendon repair kit, but it was actually designed for latissimus tendon tears by Jake Peavy. So all of that story kind of grew legs, and people heard more about it. And the other thing that was really remarkable is if you look at 2 of the major papers that were available at that time, both by individuals closely associated with professional baseball teams, they strongly recommended that non-surgical care could get the same result as surgical care. They recommended that as the proper treatment. If you look carefully at one of the studies, you could see the tendons that were completely off actually didn't get the result that they were looking for, but it had been diluted by the other cases, and so it looked like it would be okay. So there was controversy over the fact that we were fixing it because people had gotten back to throwing a baseball without having it fixed. There was controversy because there wasn't really a clear method. Should you go from the front or the back or both? And there was controversy because the actual tools that we had were not set up for this. And as I worked through all of this, my singular thought was, I don't want someone else to go through the same anxiety that I did. I'm going to describe what we did. We're going to talk about the operation, and we're going to make better tools to make this thing come together. And so with all of that, I became known as the guy that fixes lat tears.
Yeah. And it seems like velocity, I'm assuming, is one of the main things that is predisposing these pitchers to this injury. Do you think that's, I always say it this way, like if you're looking at a pie chart, what percent do you think would be them trying to throw harder versus like all the other variables that could potentially be at play?
So it's hard to separate out all these variables, as you're already pointing to. And if you just want to look at one variable, whether it's an elbow injury or shoulder injury, you can look at the increasing velocity as being the culprit. I'm sure that we could also look at things like fatigue or too much workload or the mechanics of the throwing. But if you want to look at something that's very straightforward, just as we increase velocity, we have more of these injuries. It turns out the latissimus is a very important decelerator of the throwing arm. So when they tear this, it's at the end of the throw. They're actually going through the final part of the motion. The elbow's going to full extension. And as they let the ball go, they're trying to decelerate the humerus from coming out of the socket. But there's other structures that do. The rotator cuff is doing that. The deltoid is doing that. The lat is doing that. And in some of these players, it's enough of a force with that eccentric load and decelerating the arm that the lat will then pop off of the humerus. And so you can imagine that when we've looked at some of these players, we've noticed that some of them have increased their overall strength and size within 1 or 2 years of these injuries. We've seen people that increase their velocity, but in reality, what it is they've just gotten to the point where that lat can no longer resist the force that's required to decelerate the arm. They're either stronger, faster, or with greater velocity, causing the forces that are necessary that the lat fails and it pulls off.
And do you think this is also a malady of aging? Meaning, like if we're talking about Achilles tendon or patellar tendon, we definitely see like some metabolic disturbances sometimes. We see age as being a predisposing factor. Do you think all those are also at play? Have you found that you're operating on more older pitchers, or do you think that isn't as big of a factor?
Yeah, at first I thought that was the case, and I think it was because some of these older players were willing to take a chance at the surgery because they knew they didn't have as many years left and they didn't want to give up any more. But actually, when we've looked at the numbers over the last 10 years, it's a very broad spectrum. I have done lat repairs in high school kids, in college players, in minor league, in major league after the age of 30. And so I really believe that there's this overall injury that occurs just when all these variable factors, the biomechanics of the shoulder, plus the power and force that they're able to generate when throwing the ball, and then the lat unable to decrease this ability to separate the shoulder where, in fact, the lats occur. So to answer your question straightforward, I used to think that we would see it in the older players, and when we're talking older players, we're talking over the age of 25. So for the rest of the patient population, it's not exactly the same. So it's hard to believe a player between 25 and 30-year-olds has any kind of social determinants of health that are really affecting their overall outcome. But I really think actually can occur at any level. We have seen more and more of the kids early on with such a incredible push towards velocity. As everybody's pushing towards 100, you got to get 100. We see them in the late teens and early 20s just as well as we see them after the age of 25.
I have to interrupt just a little bit. Yeah. So we had a special delivery. And so the beautiful Kate, Dr. Romeo's wife, just delivered us a beautiful glass of sparkling Dom Perignon. So we figured there would be a perfect opportunity to have a great glass of wine.
Cheers.
And so cheers, y'all. Thank you all for being here. Beautiful. Cheers. Cheers. Cheers.
And I can tell you, if Jake was here, he would celebrate with us because I think we gave him 6 or 7 years and another $50 to $60 million of earning revenue after we fixed his lat. So it was definitely worth it for him.
Now, do they all look the same, Tony? So when you get in there, I mean, are they pulling it clean off the bone, or can there be a mid-substance component to the tear? Or what's it look like when you get in there?
Yeah, I think one of the reasons why, to some degree, I've maintained the title is that there is a lot of variability.
Right.
And so if you're not doing a lot of these and you get in there, it can be confusing. And to make it even more difficult, on one side of the equation, you have the axillary nerve. On the other side of the equation, you have the radial nerve. So you have two major nerves to the arm that you have to identify and protect. Then you have to get down to the humerus, and you could have part of the tendon pulled off and the rest of it remaining. You could have the entire tendon pulled off. You may have mostly muscle pulled off of the tendon. And even to make it more exciting, we often have combined injuries where the lat tears, but so does the teres major, which has little to no tendon. And so you see a muscular portion pulled back, and you're wondering to yourself, well, how am I going to repair that back down into the same space? But we do see lat and teres major tears. And on the teres major side, there looks like there's little to no tendon. It turns out that if you look at the end of it or you feel the end of it, there's a very thick fibrous tissue there, and it does hold on to sutures fine. So it may not look like you're repairing a tendon, but we are able to secure that down and get that repaired into place. So the answer to your question is that there's a lot of variability. And that's why you hear some people say, I go anterior, I go posterior. It's actually, if you want to do one approach to make sure you can take care of all of them, you go posterior, because you get from the healthy muscle of both the latissimus and teres major all the way up to the injury. You can do that whether it just happened, and then it's very easy to see, or a number of these players come in after 2 or 3 rounds of non-surgical treatment have failed to allow them to go back to the same level. So now they can be anywhere from 6 months to a year out from their injury. And what happens is that space between the real tendon and the bone fills in with scar tissue. And actually, visually, it's really hard to see the difference. You have to feel, and you can actually feel the ridge of the real tendon, and oftentimes resect out 1 centimeter or 2 of this scar tissue that looks almost like it could have been the tendon that got stretched. But you have to do that to get it back to its normal length. So it can be quite variable. And so my approach is posterior approach, expose the healthy latissimus and teres major, so you see those very well, and then proceed towards the humerus, and you'll see the demarcation to where the injury occurs. A lot of people get very nervous if it says it's a muscle tear, so it's the tendon's still attached but the muscle's off. We see these also on the other side of the arm with the pectoralis major, and typically you have the same event where the tissue that's pulled off does have enough thick fibrous tissue in it that you can repair it back down into place. So the fact that it's a muscle tear that's close to the tendon or right at the muscle tendon junction does not concern me. Those we can repair. If it's mid-substance, which is very rare but occasionally seen, those are more like a mid-substance tear of the quad, where we treat those non-operatively. There's not really tissue to sew back together. So anything close to the tendon attachment, whether it's tendon off a bone, the muscle off the tendon, or some variation of that, whether it's a lat and the teres, if we get this exposure, so we protect the nerves and we go down to the attachment site, we then have a full view of exactly what's going on, and we can repair whatever pathology we see at that time.
And do you feel, is there like a prodromal phase with these athletes like there is with like UCL? Do you like, are they complaining about anything like weeks up until the actual catastrophic event, or not necessarily?
That happens sometimes, but it's actually quite uncommon. Most of the players will describe that maybe they were a little tired or they've been throwing a lot, but they won't say, the back of my armpit was really painful for a while and then now this happened. That's actually quite rare to hear that significant prodromal symptoms. Now, one of the things that I think confuses it, and you'll sometimes hear the commentators and some trainers talk about a triceps tendon strain up in the upper part of the arm. And quite honestly, I don't think that really ever happens unless the lat is injured. I think the neurologic structures in that area are very close and similar. And so I think the players feel like it radiates down the back of the center of their triceps. But if they say it's a triceps tendon strain or their triceps is bothering them, I would look very, very closely at their lat, because chances are that's where they're having some prodromal symptoms. So I think sometimes they may have them, but they get misinterpreted. But actually, many of the players will have no prodromal symptoms, and then suddenly this happens.
I've heard George, he repaired my patellar tendon tear, and he talks about the importance of length tension relationship when we're repairing tendons. When you're in there like that, that has got to be I feel like a ligament would be so easy to get that length tension relationship correct. When you're dealing with a tendon tear, that's got to be, I would think it'd have to be very precise, and you'd have to be kind of guessing a little bit on what that length would be. What are some of the things that are going through your mind when you're trying to get that relationship right? Because I'm assuming that the people that don't get back from big tendon injuries, that's why they don't get back, probably because they didn't get the length tension relationship right.
I think that can definitely be one of the explanations. Interestingly, when you're taking care of a ligament, you have a very stout structure that has an attachment point on two separate bones. And when the joint goes through a range of motion, it's relatively isometric, which means there may be a little bit of stretch, but not stretch through the whole range of motion. And so it's actually critical that you get the ligament attachment points just exactly right, or you're going to have laxity of that joint. So that is a really critical point. The tendons, the length, the muscle tendon length is very important, and it's critical to get that right. But we have a little bit more of human adaptability on the tendon muscle junction than we do on the ligaments. Like if you get the ligaments wrong, you make them too tight, the joint's going to be stiff. You make it too loose, they're going to be unstable. I think that this latissimus is such a big structure. It has so much flexibility to it that I think it will adapt to slight variations in overall length. As it turns out, which is very similar to what we see with the pec tendon, our surgical goal is to identify the normal tendon, to prepare that tendon, and also to prepare the bone. And we say prepare, we just scrape it a little bit so it gets a little bit of bleeding, because that becomes the glue that holds it together. And then by any means whatsoever, if we can get that tendon, the natural tendon, down and touching the bone, the body will figure out the rest of the length. And so in this area, we oftentimes are in a situation where we use a technique. There's a special technique that's called the tension slide technique. And what it is we put the suture in this button that we talked about. So it has a sliding pulley, and we take one end of it and we suture that through the tendon with a tendon holding stitch. And the other side, you don't even have to put in the tendon. And so then once we get everything lined up, and usually it's 2 or 3 points of strong fixation, you pull on the side that's not in the tendon, and that draws the entire tendon directly down to the bone. And if you can imagine, to see this area really well, you have to put the person's arm in abduction, almost like a throwing position. But if you try to do that, it's sometimes almost impossible to get the tendon even close to the bone. There's such a big gap there. The muscle's contracted. There's just no way. So you have to bring the arm down by the side, which then limits the space that you have to work and the view that you have. And so that you use this technique, the tension slide technique, and you pull sequentially on these 3 different sutures. And before you know it, it's all the way down to the bone. And then we tie our knots very securely. We oftentimes use a suture, but also a small tape that is even stronger at holding tendons in place. And at that very moment in the operating room, if we went to move the arm, the athlete would not have full range of motion. We would not be able to get their arm up above their shoulder completely, or to get the external rotation. In fact, it may be reduced by 30, 40%. And so that's the contracture that's happened in the muscle, primarily in the muscle. But what's remarkable is that we leave the arm by the side. We start just gentle, simple range of motion activities for the first 4 weeks while we're letting the swelling go down, the healing go down. The muscle relaxes and it regains its overall length, at least from a functional perspective. When we measure the range of motion, usually by about 6 weeks, they're back to their full range of motion, even though at the time of surgery, we couldn't even come close to that number. So the muscle relaxes, the myotomes go from a contracted position and stretch out. And so I think in this area in particular, we have some human flexibility that gives us a little bit of, you want to call it a fudge factor. We just have to get the tendon down to bone, and we know if we do that, it's going to heal in a pretty good spot.
Tony, sorry. So shortly after this surgery, you explained it to me in some detail. So if I have it wrong, this was years ago now. But I think what you were just describing there, didn't you also not necessarily attach it back to the bone where it would have been originally, and you still found that adaptation that you were just describing?
So no, we try to attach it down to the bone. Pretty close to the same area. It might be off by about 5 millimeters or so just because of the angle and things, but actually we do try to get pretty close to the same footprint. The other thing that we do is the latissimus has a lot of attachments to the dermis of the skin. And so when we have these tears that are very big or they've been there on a chronic basis, we have to loosen up the attachments from the dermis down to the muscle, and we free up that fascia so the muscle has a lot of flexibility to it. But we do try to get it down to the footprint, but even with someone like Jake Peavy, there was no way. I think by the time we went to the OR, we measured about a 10 centimeter retraction, and by the time I got it back into place, we were not able to get anywhere near as normal range of motion. But we're confident that that muscle will adapt to that over a relatively short period of time, and they are able to get that back. I think two things. One, the muscle adapts, and the other thing, this is an extra articular reconstruction, so the joint itself doesn't react adversely. So you can do certain operations like rotator cuff surgery and you repair it down, and maybe you've got the tendon exactly the right length, but there's a capsule and there's a joint with very active cells from the synovium, and I think that increases your risk of getting a stiff joint and having trouble with the range of motion. That's not the issue with this one because it's outside the actual glenohumeral joint.
Different parts of the body, you see the same anatomical situation where you literally have a twist in the muscle. You see it in the lat, you see it in pectoralis major, you see it levator scapulae. And I've heard it likened to if you looked at the Golden Gate Bridge where you have a coil in the cable.
Good night, Gigi.
Night, Gigi. You're a superstar.
Thank you.
Yeah. And so it's a really anatomical, unique muscle. I'm sure it's kept you up late at night kind of thinking about it.
Well, it's interesting because, there's a lot of structures that have these unique twists, and I think sometimes we observe them and don't really know why they make a difference at first, but then over time you realize in terms of the range of motion and movement that it's really critical to get this correctly.
To throw baseballs.
To throw a baseball or to be able to create.
Throw rocks.
It's amazing because we're talking about range of motion in the X, Y, and Z plane, but it's really global motion. It's a meridian plane or a circle that's moving around. So it's not just X, Y, and Z, it's everything in between that. And the way that the lat tendon comes up and rotates into the humerus and has the flare that it has to go into the correct position, it allows us to get not only the elevation, but the external rotation. The tendon adapts to that and actually rolls and lays over the top of the humerus as you go into maximum external rotation. And then as you come forward, it releases from that. It's not attached in there. So it has a landing point. And that if you don't put the tendon in the right twisting position, you actually will irritate or restrict that motion because it can't rotate nice and smoothly over the top of the humerus the way it was designed.
I think we kind of touched on, maybe after your question, we touched on the non-surgical option here, and maybe Julie has a little bit more of insight into this too, but what does that non-surgical patient look like? Or, what does the non-surgical approach look like? We've kind of dove into that, but is there a patient that you see in your office that you say, this looks non-surgical to me? Or, kind of what does that thought process look like behind the scenes?
Yeah, so almost 14 years ago, we didn't know what was surgical and non-surgical. Actually, we fixed Jake's. We then got a number of players that came to us say, I've never really made it back, and it's kind of really bothered me. So our next 10 or 11 players, the average time to fixation was almost 1 year from the time of injury. They're all chronic. They're all players that said, I never really got back as much as I wanted. It really bothered me. And I would fix them, and I was pleasantly surprised that I was actually able to do that based on the principles that we've already talked about, because it does get a little scary with all that scar tissue and nerves and everything. It gets, but you can figure it out. But it's nice to have some experience to be able to see that pretty well. So I realized that you could do these relatively late. And then I had a couple of other experiences. I had a couple of bodybuilders who had ruptured these and were 2-3 years out, way out. And I told them, I said, listen, I don't know. We've never done them that far out, but we've done that with the pec and we've been able to get the right answer. So if I can get any part of that lat tendon back down to bone, you might end up stiff. So you may get your V back, but you may not have forward elevation. And these two, I remember very well, both got their motion back, were able to lift, and were so excited because they lived with deformity. And of course, if you're a bodybuilder, that's a big problem. And so, but now they were able to fill that back out again in a way that was more normal. And so to answer your question, I wasn't really sure why we don't fix all of them. We do that in most other tendons. And so we tried very carefully to look at the HITS database for Major League Baseball, the health injury tracking system, that the Players Association, the Commissioner's Office, and a group of physicians were willing to put together and collect that data with some supervision from the Johns Hopkins Public Health Department to make sure the data was all pretty well filed and collected and accurate, and also de-identified. And when we looked at it really carefully, it took us quite a bit of time to realize that what we were seeing is that the players that had some part of the tendon attached, a number of them were able to return back and never sought surgical treatment. And the players that were completely off, a lot of them actually returned back, but their sabermetrics or advanced analytics were off. And so we really started to separate this out. What we believe is that if you have a complete tear, a 3 or a 4, it is possible to return back to throwing. But because it's so important in the deceleration part of your throwing, mentally, it's very hard for you to get back to the same level of velocity. They usually use 2 to 4 miles per hour, and they don't have the same stamina. And we saw that fairly consistently. So we say if it's completely off and you have time for an extended career, it's probably in your best interest to have it fixed.
You know what was unique when I was looking at the data on it? So even in a conservative arm where they didn't do surgery, they were still out 99.8 days. So that's a long time. I mean, like, and then if you end up doing surgery, I mean, like, you're out, a very, very long time. So, I think it might make an argument for if you're a surgical candidate, you're probably going to want to pull the trigger on that, I would think.
Well, that was really the issue. And I still get those calls almost every week. Does this guy need surgery? And if I see any part of the tendon attached to the bone, my most common default is no, we should see how he does clinically first. Because 2 reasons. One is because a number of these actually returned back and did pretty well. They scar back down. It's almost like the hamstring off the ischium has 3 parts to it. And if at least one of those parts, especially if 2 of those parts attached, they usually do pretty well. They don't have to have their hamstrings repaired. When the hamstring's completely off, they actually oftentimes in explosive sports can't do as well. And I think the lat may be something like that. When it's completely off, it's really hard for the athlete to get that same level of balance back because of how important it is to decelerate. When some of it's on, I think they scar back into place and they may learn how to throw well. They might lose a little bit of their velocity, but they're able to return back. But I think what you just pointed out is really, really important. And that's if any part is torn, I tell the teams, you have to be worried about a 42 to 90-day recovery. It's not 2 to 4 weeks. It's 6 to 12 weeks. Right. And the more that's torn, the more likely it's 12 weeks or it doesn't heal at all. But the other reason I say it's okay to treat that non-operatively is because if it fails, it's right there. Right. It hasn't retracted, and it doesn't generally do that. If they fail, usually I see them fail in that first 6 to 8 weeks. As soon as they turn back to throwing, they feel the same symptoms again. It doesn't feel like it's any better. And if we go to fix it, everything's right where it should be. It hasn't retracted a long distance like it would if it was completely off.
Right.
And if it's completely off and we wait 6 to 8 weeks, it's stuck. And I have to really work hard to get it back into place. Now, the seasonal part of it plays a role too. So if this injury occurs, somewhere in the first half of the season, we would like to treat it non-operatively if it's going to have a chance to do well so they could get some part of the back end of the season. But if it's for instance, a younger player and it's a 2B, it's almost completely off, and we're in August or September, they may very well elect to have it fixed so they're ready to go by the All-Star game. So they don't so they don't try to go through the rehab and then come back and it doesn't work. Now you're at the front end of the season. It's going to take them the entire next season to get better. So we do have to keep that in mind, that the recovery from this is at least 9 months, but most of the players will tell us they don't feel like they're really hitting their slot and they're really comfortable with their throw till about 12 months. And sometimes it even takes a little bit longer than that. So if it happens early in the season, we may give them a little time conservatively to see how they do. But the later the season goes, the more likely that, especially if it's a completely torn tendon like a 3 or a bad 2B that doesn't get better, we'll get them to surgery so they can at least get their next season back.
And those 100-ish days, sorry, you just think that they live their ADLs and they're throwing ballistically, but maybe not at 100%?
That's exactly right. I think they don't really feel the lat. I think somehow subconsciously they mentally protect the lat. They use their rotator cuff and the other structures. And the reason why I say that is because one of the more common symptoms we see, which we saw on Jake Peavy, is when they come back at around 9 months or so, they get rotator cuff tendonitis. And it looks like rotator cuff tendonitis. They have like an impingement syndrome. They'll have an impingement sign, and you inject the subacromial space and they feel much better. And I think that's because subconsciously they're overloading the rotator cuff to work as their primary decelerator while they're continuing to allow that lat to catch up. So they're going through that, and subconsciously their brain is working on that balance. And as they throw harder and harder, especially when they start getting above 70, 80% of their normal velocity, they've got to start using all of their different parts of their shoulder to work well. And at that point, their rotator cuff may try to substitute for some of the lat deceleration, and they get rotator cuff tendonitis. And normally, we don't have to inject them. Sometimes you do, but you just slow them down. You give them 2 to 4 weeks, and usually that allows the lat to kind of catch up to them, and that symptoms will go away. So I've seen a number of players in spring training where they get some rotator cuff symptoms, and obviously to make it even more complicated, most of these players have had prior MRI that shows a partial rotator cuff tear or some type of rotator cuff injury. So they've had it even before their lat strain. But now the team is asking, well, is that rotator cuff tear the reason why their shoulder's hurting? And, if they've been doing well and all their symptoms was related to the lat before their injury, and now they have symptoms, I strongly believe it's because the rotator cuff is trying to compensate for the recovery of the lat, because we've seen so many of these athletes now go on with a short period of intervention to do well. So to summarize my point is, if any part of the tendon is attached, our default pattern in many cases is treat it non-operatively, see how they do. If it's almost off and the athlete is very symptomatic and very sore, and it's sort of towards the end of the season, and particularly if they have a young career, we might lean towards fixing those early. If it's completely off, we recommend that they should be fixed to give them the best chance at achieving their pre-injury level of sabermetrics or advanced analytics. That being said, not all of the athletes choose that route. Many of them will still consider non-surgical care and see how they do, but we recommend that because our evidence-based data would suggest that was more consistent in getting back to the same level they were before their injury.
Julie, we were in Breckenridge. Well, I'd probably had 3 Aperol Spritz at that point. We were in this wonderful conversation, and it was funny when we brought up Tony. I mean, I was like a pipe dream. I'm like, can you get Tony on the podcast for us? And you said you didn't talk anything about him being a good surgeon. You talked about like the soft sides of him, just like being a great clinician. There's no soft side of Tony Romeo. You're sitting next to him, like just this man's hewn from granite. But if you what are some of the things that like being around him that like he's done really well outside of the surgery part? Like what does he manage cases well? What are some of the we call them like the soft clinician skills that?
And that's a great question. I'm glad you asked me that, Tony. I mean, now I'm gonna get all soft on you. So I did my training and fellowship in 2013, and every Wednesday I was with Tony all day long at the Oak Park office, seeing 70, 80, 90 sometimes patients, Tony. It wasn't just me and Tony. It was Tony and a team of other great people. But that was a huge highlight of my year of sports medicine fellowship, which is really unique in in primary care sports medicine fellowship training to have that experience with a world-renowned surgeon particularly. And I feel like I was shitty at shoulder before, and they were like, you're going to go work with Tony Romeo every Wednesday. I was like, oh my God. And I like had to bone up on all of these, all of the special tests and all that stuff, whatever. But what really struck me, and Tony and I have had a really lovely friendship that blossomed from him being a mentor and still is. And there's I had a lot of opportunities to co-manage even after my fellowship when Tony and I were still working in the same practice, where we did a lot of collaborative co-management of patients. So where I would be the people, the doc kind of triaging and saying like, hey, is this someone who really does need a surgery or doesn't? And that reminds me of a question I wanted to ask you, because Tony, you brought up MRI stuff, especially with the lat. So I'm reminding myself to remind myself of that. But some of the language, Tony, that you've used, I've continued to use in my 10 years of practice, and giving people the opportunity to, you give a nice explanation of what you think their problem is. So you listen to them. You listen to their story, you validate their concerns, you give your reasoning as to why you think this is the problem that they have and what's the evidence-based practice behind it to support and give them choices of what their next steps should be. And there was many times when Tony was not recommending surgery for somebody because it wasn't the appropriate choice, even if they were clamoring for it. Some people don't really know what they're asking for, and then you explain a little bit and you're like, oh no, I don't want that. That sounds terrible, But he pretty much always ended the patient conversation, and you could just tell when you were kind of winding things down, was what questions can I answer for you? And I will always use that language. And I teach the students and the residents and the fellows that work with me, and I always cite that I learned it from Tony Romeo, was not like, it's never a yes or no. It's an open-ended question of what questions can I answer for you now that we're done? Now that I'm done, giving you my lecture part. And it really takes people, they're taken aback by it, because they're expecting to be like, okay, bye-bye now. I'm done with no more talking. That's all the time you get. See you later. You can go talk to my PA, And it's a little thing, but it meant a lot. And I think it really means that language matters. And I think it doesn't take a lot of time, and it doesn't take a lot of, overthinking it to show somebody that you are worthy of their trust. And I think that's an incredibly important thing that a lot of clinicians and physicians don't always remember, is that it's our job to prove to our patients that we are there to advocate for them and that they should be trusting us. Just because they walk in the door because, they know it's Tony Romeo, or they know it's Brett Winchester, or that we still owe them the duty of proving to them that we have earned their trust, and we're worthy of their trust, and we will continue to do so. And that's really one of the biggest things that I learned from working with Tony and being his student to some degree. And
a vignette that sort of ties in that a little bit is I was referred a player from one of the West Coast teams, and he was 31. And so, quote, towards the end of his career. And he tore his lat, and he was a closer. And they did the conservative treatment for about 6 weeks, but when he started getting into the low 90s, it started bothering him again. So they sent him to me to have surgery. And so I went over everything with him, and he did have a grade 3. It was off, not badly retracted, but it was off. And when it was all done, I said to him, what would you like to do? He goes, Doc, I'm almost done with my career. I don't want to take a year to rehab. I think I could be clever enough if I'm not throwing 97, 98, if I'm throwing 92, 93. What happens if I try to treat this non-operatively and it doesn't work? And I said, well, I can fix it then. He goes, you can fix it even if it's late? And I said, yeah, if you come a year from now, I can still fix it for you if that's what you want to do. He goes, well, they never told me that. And I said, no, it's fine. And he says, well, what should I do? And I said, it's a little bit investigational. It seems to work a little bit in hamstrings. Why don't we try some platelet-rich plasma injection? It's a very easy place to approach with ultrasound, can be done safely. And so he ended up having 2 of those, and he got back to closing, and he got traded in August. And he got traded to a team that went on to win the World Series. And so he got his World Series ring because we did not operate on him.
There you go.
And I received a very wonderful gift from him and his wife. It was
come in a bottle?
Well, it was related to Gigi. His wife has a place that has related to children's clothing and gifts and stuff. Aww. And they sent us a gift for Gigi and just said, thank you for extending my career. And I extended his career by not operating on him. Yeah. And he actually went on and did pretty well. He was definitely less, but he was an older pitcher and clever and could be effective without having to throw 97 to 99 miles per hour. And so, again, I think that we have these very important guidelines. We have the evidence, but in the end, as Julie said, I asked him, is there anything else I can answer for you? Because what I really want to say, what do you want? Yeah. I'm happy to bend you. Yeah. I'm happy to bend the rules here, and let's do it non-operatively. If you don't get better, we can fix it. As long as you accept the fact that you may end up missing another season. If that's what you want to do, I'm okay with that. I'm not going to be paternalistic, say you have to get this done because if you don't, I can't fix it. I can take care of it for you. And I think that that's really important. Is the athletes are often told something that's almost like dogmatic. You have to do this. Yeah. And I think there's certain cases, I would not want to be a high-level pitcher and live with a torn UCL. That's probably not going to work well for most of them, although there's examples where it has. But in the lat area in particular, I think there are a little bit of forgiveness at the borderline. So I think it's very important to go over that with the athlete, make sure they understand the recovery time, the return to throwing, and all of that. So I think it's important.
Do you think that if we just went through like the continuum of this injury, if we went to imaging, so you have an athlete that you're suspecting a lat problem, sounds like they're going to be kind of grabbing at the armpit area and like the posterior wall of the axilla. As far as imaging goes, do we use a standard MRI or using arthrogram or using like a lateral view of the thorax? What are the best ways to view the injury?
I rarely use arthrograms in any of the studies that I do using MRI because the arthrogram is a fluid that creates a very bright white light. And what it shows is separation of tissue, but then it obscures the gradations of injury to the other tissues. Like to see a problem with the muscle that's away from the joint could be obscured by the brightness of the signal from the fluid. So I rarely, if ever, use arthrograms for any patients for any condition, to be honest with you, because I think the MRI gives you a lot of information about the soft tissues away from the joint without that actual information.
We actually heard the same thing from Tom Bird, the hip guy, on our podcast. He said that he's totally off arthrograms now.
Yeah. And so I would not do an arthrogram. Most of these athletes have a shoulder problem, so the study that's going to be routinely ordered is an MRI of the shoulder with a shoulder coil. And that shoulder coil gives a very nice view of the shoulder joint. And typically for higher level institutions, they'll get cuts at around 3 millimeters. When you're going to a strip mall MRI, you may get a 4 or 5 millimeter cut, which means that the computer is asked to take cuts that are 4 millimeters apart and then synthesize that information into a signal that you have to read. And so you cannot see the same detail at all. And so one of the first things we do is we check and see how many, what's the layer of the slices and make sure that's good. The second thing is I want at least a 1.5, but now we oftentimes use a 3.0 magnet to get a little bit more clarity. I don't think it's absolutely necessary, but it's nice. And the last thing is that with the coil, it usually stops right at the level of the humerus where we have the blood vessels of the posterior and anterior circumflex vessels. The problem is the lat starts right below that. And so what you see is on the axillary view, which is the cut through the bone, you'll come down to the blood vessels, and then you'll see just below it, there's some signal change on the lat, but you don't get enough of the lat to really know what's going on. And so a lot of people may miss that if they're not very careful about seeing it. Plus, it's hard to see it in the axillary view. So what I suggest to the teams is get a standard shoulder view so we can look at all the things that could go on there, rotator cuff area, this, and then get a lateral chest wall view. Some people interpret that different ways. They will get, some radiologists will get a lat view or whatever, but if you get a lateral chest wall view with 4mm cuts, you, as the orthopedic surgeon who doesn't look at this view hardly at all, except in this situation, your mind will easily see the structure of the latissimus, the fibers of the muscle, the tendon going to the bone, and the teres major, and you can read what's going on for sure. And not only can you read if there's a tear, but you can tell whether it's a 2A, a 2B, or a 3. So many times I get sent a patient who's like, we think he's got a significant tear. Our MRI doesn't show it. We'd like you to take a look at it. And I'll say, before you send him to me, please get a lateral chest wall view. And they'll do that. And oftentimes they'll then give me a consultant access to the Major League Baseball PAC system. And I'll just show it to him. I said, see, if you look at the lateral chest wall view, you see exactly what's going on. You can send them to me if you want to, but you have the diagnosis. It's right there. And so I think what you need to get a little bit further down than a standard shoulder MRI. So you can either do that by asking your technician to extend the MRI view just below the coil so they can see the lat attachment. That's one way to do it. You can do it also by getting a lateral chest wall view. Then you get all of those structures, including the triceps, the lat, and the teres, and you see those. And even as an orthopedic surgeon, you can make out those structures, and that helps you be more confident with your diagnosis.
I feel like that's a great point. And not every patient that we're taking care of, though, is a professional athlete. And so do you ever get pushback from, I don't know, I feel like sometimes when I ask MRI to be like, can you just extend it down a little bit? One, they'll just like, you like hear their eyes rolling of like, ugh. Or they'll ask you to get a completely other MRI, which is fine, but like not everybody has the resources or the, wanting to pay for two studies.
$500 or something.
Yeah, or their insurance company is going to call you and say, no, we're not covering that. And you have to do a peer-to-peer on it and talk to some retired pediatrician who's never looked at an MRI.
The answer is yes, we do experience that. But my feeling on that is that
you just say who you
there's
are.
a lot of really good radiologists. And so I don't want to,
No, I'm being silly.
No, I know you are. I know you're just being humorous about that. But
sure.
My comment on is, listen, the radiologist has to make the diagnosis. I have to come up with a treatment.
Yeah.
If you don't give me any more information, the radiologist can do the surgery.
Well, the thing is, like, the radiologist is not making you a diagnosis.
It's the technician.
The radiologist is reading a bunch of things on a screen. Yeah. And I love that you bring up, too, and that's another thing that you taught me, was like, look at the images yourself. Yes. You cannot rely on another clinician or a physician who is very, very well trained, but they're looking at it through the lens of someone who's never met this person and doesn't know what's wrong with them and doesn't understand, doesn't have their experience. And not to crap on radiologists, God bless them, that's why they get paid the big bucks. But you're absolutely right. And the question that I was going to ask you about is, like, have you ever been surprised? Have you ever been surprised when you looked at it with your own eyes, especially if you got the right views and you got in there, you're like, oh shit, this is way worse, or it's actually not as bad as I thought it was going to be?
Yeah, I won't bring this subject up, but I actually operated on a kid that was sent to me with MRIs that were not his MRIs.
Oh, geez.
And when I got in there, his lat was...
Oh, no. What a nightmare.
So he had a muscle strain. They somehow mixed up the numbers.
No.
And I looked at the MRI and he had a tear. And the radiologist called it a tear. And his dad saw it was a tear.
Uh-huh.
And we operated on him. And I took pictures in the operating room to show him what it was.
Fine.
Say, this is what we found. And he goes, well, where's the tear? I said, exactly.
Mm-hmm. What tear?
And so I went back to his MRI. So I sent his dad the pictures of the MRI, the pictures of his shoulder, and said, you need to go back to the radiology department because I think you're going to find there's been a problem. And sure enough, it was a mistake. So it can go to that level.
That's nuts.
But I think the important thing that you mentioned is you have to read your own MRIs.
Totally.
The MRI should confirm what you think clinically. In this case, it's a little bit more than confirmation, because if you're going to consider treating it surgically or non-surgically, you really need to know a little bit more about the anatomy. So you need to see it. And I think you're right a little bit about the comments you made. Well, because you're Tony Romeo, I am sent people that have already seen another physician oftentimes. And if they want to come to me and they want my opinion, I will say, I'm not going to give you my opinion with less information that you've already given to some other doctor.
Yeah.
So if you can't get the MRI from me, or you can't bring it for me to look at, then I really don't have any additional information I can provide to you. And, and patients, I try to say it in a nice way, but the reality is that it does take extra work on the patient's behalf. And sometimes it can be a real pain in the butt to get it, or the athlete. The higher level athletes have their agents get it, so it's not an issue. So it all works out. But I if I'm going to decide whether they need surgery or not, I want to be convinced with my own two eyes that that is a surgical indication. So I am okay with the fact that if they've got an MRI and that's all they have, and I can't really see it, I say, I don't really know if you need surgery or not. And so, we're either going to have to give this other view, or we're going to treat you non-operatively, because I'm not going to just do surgery to find out what's going on.
Yeah, and I think great points. I freaking love it. If we could switch gears just a little bit, something you said a couple times throughout here. You've talked about the feel and the touch, and Brett and I and Adam were heavy manual therapists, and so we rely on our touch so much. But if you could maybe just talk about where your physical exam comes to this. I'm going to guess, we've had just some amazing orthopedic surgeons, and they all talk about the orthopedic clustering, and it's always not one thing, it's always multiple. But how much does palpation and how much does actually your feel and hands-on of the physical exam, maybe preoperative and then during surgically, actually matter? And where does that kind of take you as far as maybe understanding the length tension ratio, and just kind of talk about, where your actual hands play into surgery?
I think that I can honestly say that with a history and a good physical examination, I'm pretty clear on the diagnosis 90% of the time. And the radiographic studies will help confirm that. And then the 10% that are more confusing are often very confusing. They may be unique. When there was this big move with COVID for telehealth, and people would ask me, how much do you think that's going to be part of orthopedics? And they were predicting 30, 40%. And I said, if that's the case, orthopedics will be terrible. I said, if it's more than 5%, if it's more than just following patients up after you're treated on them, you're going to miss a tremendous number of diagnoses. The only things you're going to pick up as bone problems from x-rays. You're going to miss all kinds of soft tissue problems. The people that make those decisions think that MRIs, and I think Julie was going to talk about this, that MRIs basically give you the diagnosis. But the fact of the matter is that as we go through our life, the tissues in our body have a number of variable injuries to it, and it changes signals. And it can look like a degenerative tear. It can look like a strain. You may even have a full thickness tear. We talked about this earlier, so I won't bring up his name, but we talked about a very famous athlete. And when I went to do his shoulder replacement, I was shocked to find that the leading edge of his supraspinatus tendon was torn, because he had such tremendous strength. We didn't even do an MRI. We just did a CT scan to measure the implants. And it was torn. And I asked him after surgery, when did that? He goes, oh, I think that happened my freshman year of college when I dislocated my shoulder. I said, when you dislocate, I never heard that. He goes, oh, I didn't tell anybody. I just put it back in place and kept playing. And this is a guy that went on to win the Heisman Trophy. And I'm just, I was like, okay, and
Speechless.
so we have to be able to correlate the patient's deficit that we can determine from our exam, have a inductive reasoning of what that might be, and then the MRI can just help confirm that. If you're using radiology, then you're no better than a radiologist, and I don't think they get much surgical training. So I would not want to have a radiologist operating on me, and they don't want to do it either.
Right.
Yeah.
It's out of their expertise.
Yeah. And so when we get an MRI of one of our high-level professional players, particularly from the Cactus League, the radiologists there are outstanding. The typical report's 3 pages of pathology. And we're looking for one area that's about 1 centimeter to know whether that's the problem or not. And there's 3 pages that comment on every single signal change. And then it's our job to correlate that to the clinical findings. So when I put that all together, for me, I think the thing that we're going to have a real problem with as we go forward is that with all of the type of reasoning and advanced computers and the AI that we see, there is a level of human intuition that we're never able to capture. It's never going to happen during my lifetime. I mean, that's why people are doing things like buying companies like Twitter or X to try to learn about the human way of thinking about things so they can put it in their robots so they are more humanoid in the way they do things. But imagine how far away that is from the way real people are. And that's the highest level that we're working at right now, with over 1 million times increased computing in the last 5 to 7 years. And that's the level we're achieving. And I can just tell you, there's just nothing better than putting your hands on a patient, feeling the way the shoulder's working. You can feel things that they can't describe, and saying, is that what bothers you? And they say, no, I don't. I've had that for a long time. Well, nobody knew that, but you know it now. And so then you start removing some of the things and you come down. So that's the one thing. So let me repeat it a different way, a different way. Now I know that's the thing that really bothers them. And if I'm going to operate on them, I may have other things I do, but if I don't take care of that one thing that I'm able to reduce, to completely replicate in the office, they will feel like they didn't get the operation they were looking for. I have to solve that problem or those two problems for sure. And then there may be other things I might be able to help them out with, but I need to know what those are. And I can only do that with the patient awake and an interactive examination to do that. And I really think that, one of the things that was really nice working with Julie is that she was a primary care physician. So I know she wasn't going to be doing the surgery, but she was actually really interested in coming up with the right diagnosis and would kind of, kick herself in the pants saying, God, I thought I had that one. So like one of the
Tony's clinic saw some weird shit though. Let's be serious. You were seeing people that already had 4 surgeries. So when I got it wrong, it was like a hard one.
No, but my point is,
being right.
My point is with Julie is that she had a desire and a competitiveness to use the history and physical exam to get the right. And so for me, to invest in her education, being her mentor, was totally worth it. Because I knew that she would take that with her and pay it forward. And that's one of the things that I really get frustrated with sometimes when I'm trying to teach someone, and you can just tell that, well, what did the MRI say? Or what we oftentimes see today is you walk into the room and a resident or fellows presented the patient and said, Mrs. Jones fell, and her MRI shows she's got this rotator cuff tear right there. So
who gives a shit?
Where does her shoulder hurt? And he goes, well, she's got this rotator cuff tear. Mrs. Jones, where does your shoulder hurt? And it's like, it's just really, for me, it's very scary. I think there's still a lot of good training out there, but I can't, obviously you hit a hot spot for me. I can't emphasize enough that the reason why I've been in practice for 35 years, and I think that I have results that speak for themselves, and I have been fortunate enough to stay out of the courtroom for 35 years, is because my whole goal is to take care of the reason why the patient is there. And that's my focus. And that may or may not be consistent with the MRI, but it's most likely consistent with their history of their physical exam.
Yeah. Well, I think we kind of talked a little bit off air about value-based care, and I think that we're unfortunately slowly maybe going away from patient-based care. And I think to kind of echo what you're saying and maybe what you have said about what makes him so special is it's patient-based care. Meaning like the patient that's in front of you is who you're treating, not the MRI results or that kind of stuff.
And that's exactly what Tony just said. I mean, the patient, and I say this to almost everybody I see. It's like, you are the expert on you. I'm not the expert on you. I'm a consultant here and I'm here to listen to you. But like, you're absolutely right, Tony. I mean, I would agree. Probably about 90% of the time, I feel like I've got it just with hearing their story and watching them move and letting them show me. And if you're not reliant on that, then you're probably going to get it wrong a lot more than 10%, because radiographic findings are not diagnoses. Like even when it grinds my gears, even when a radiologist writes tendinopathy. Tendinopathy is a diagnostic finding in someone's, and it's a clinical. It's a clinical diagnosis. It is not a radiographic finding. And if you ask, this was so great. I had Jill Cook, who's a physiotherapist and PhD down in Australia, who's unbelievable. She just spoke at the NBA Team Physicians Association, basically just telling us we're all just doing it wrong, which is unbelievable. And she was unreal. I loved her so much. And she was talking about when you ask a radiologist, I feel like I'm shitting on radiologists during this. I have very nice friends that are radiologists. We still love you so much. But if you ask a radiologist, what's the inclusion or exclusion criteria for a partial thickness tendon tear, and they act like they're what was it, Nancy Reagan, when she was talking about pornography? Like, I know it when I see it.
Yeah, right.
There's not an actual, like, an agreed upon diagnostic criteria. And it's like, well, then what are we all doing? And if we're relying on that as clinicians to make major decisions about people's lives, whether or not they're having surgery, whether or not it could be potentially ending their career or allowing them to walk around with a big old World Series ring, it matters. And again, it's like, we are detectives. And that's what I love so much about what you guys do and with DNS, is that I think it's way above and beyond even what my training was to perform a good physical exam. I feel like I look at what you guys do and I'm like, oh, like I'm in the Stone Ages, you know? And you watch Pavel go and work his magic on one of the Major League Baseball players last month when I sneaked in during one of your conferences. And of course he was exactly right after examining somebody and looking at their stereotype via a DNS lens. Of course he was absolutely right with the two players I saw that he could pinpoint exactly what their injury was. And I guarantee it that's a much more accurate assessment of someone's problem than even a 3.0 Tesla coil MRI.
Yeah.
Tony, it was kind of crazy. She brought up the name Jill Cook.
Yeah.
So she kind of exposed this fact. She was talking about the patellar tendon, Achilles tendon, where these people have like these acute tendinoses or whatever, and then they have a image finding MRI, and then they 6 weeks later they go through treatment and they're 100% better, and they look at the MRI again, it's the same mucoid changes, nothing has changed on the imaging at all, although they're 100% better, which is kind of question the whole thought process of how these patients are actually getting better. So do you have any thoughts on that? I know it's a little bit out of what your world, but I mean, it's kind of fascinating, really. And
No, the cuff would be the same too,
No,
right?
I think there's a couple of areas where that correlates to that, and the rotator cuff is definitely one of them. And the other thing too is, the endpoint of treatment is arbitrary. So there's this study at Vanderbilt that we all know about. It's called the Moon Study, and they've looked at rotator cuff tears, and they looked at the non-operative treatment of rotator cuff tears. And what's really amazing is that if they took patients that came in with a chronic rotator cuff injury that had pain and they treated non-operatively, 75% of them within 3 months felt better and didn't have to have surgery and had a rotator cuff tear. The correlation was most heavily towards whether they believed that physical therapy was going to make a difference or not. So if they believed and the physician told them therapy would make a difference, they had a higher likelihood they would come in at 3 months and say, my shoulder's feeling pretty good, I'm going to live with it. What does that have to do with the actual tissues? Okay. So there's a huge part of this that's related to the way our bodies perceive pain and inflammation, and also what our bodies do to create that. So that's one example. Another example, a recent study that was done by the group with the Philadelphia Phillies, is they looked at players who threw a baseball, and they did MRIs of their elbows right after they threw a baseball. And what they were trying to look for is if you got fluid in your flexor pronator mass, then that would normally be called inflammation or flexor pronator mass tendonitis. And there's a correlation with that condition and the development of a UCL tear. In other words, you're at risk. Right. And what they found was that there are some players that go into the game with an MRI positive flexor pronator tendonitis that have no symptoms, and after the game they have the same amount of signal change. And there's other players that have no signal change before, and then they go through the game and they have signal change after, and they don't really have any symptoms. There's a little bit of soreness there from throwing. And then there's a group that actually it changes and they're sore. And so when we take a single point in time and see fluid and we say, oh, that's a risk of a UCL tear because there's a flexor pronator tendonitis, we really don't know what we're talking about. We don't know for sure what that means. There's probably a correlation there, but it's probably something we talked about before. If you take a select group of people that have a high risk of UCL tears anyways, then any abnormal finding is going to be correlated with UCL tears, even though, in fact, if you took a much broader population, you would see that can vary quite significantly. So I think the challenge for us is that, and one last thing about the timing. So let's say you do a rotator cuff repair in that Moon study group. They've now looked at 10-year follow-up studies, and they're having a hard time telling a difference between the patients who had a rotator cuff repair and the ones that are treated non-operatively 10 years out. So it's almost as if surgery is just like a few-year Band-Aid that helps you feel better, and then you basically go back into the natural history of your rotator cuff disease. And I'm sure that's not everybody, but the point is that we place too much emphasis on a single point of information as providing us the information we need to treat this patient over their future or their lifetime. And again, I think it comes back to the fact that when you have a single point in time, you need a history and a physical exam, and if the MRI lines up and the patients have a significant deficit that you can alter, then you take care of that. But don't pretend that you've saved that person's shoulder or elbow for the rest of their life. You've taken care of that moment of time. You've made that better. And it's very likely in many cases, if you were patient and the patient was patient, they could handle the discomfort and the limitations, and they waited long enough, it probably would gradually burn out. They probably would do okay. It's not everyone like that, but I think we really place a very strong emphasis on these acute management things. And I think it makes sense for the way we live our lives, but we have to be a little careful about saying that the things we're doing actually changing the natural history of that joint. We learned that with ACLs a long time ago. I mean, basically, you reconstruct the ACL to protect the meniscus, because that's really what dictates whether that knee's going to get arthritic or not. And if they had an ACL tear, you never fix their ACL, but their meniscus getting torn, their knee would be fine. But once the meniscus goes, then their cartilage sees abnormal forces in the joint, and they're going to get this. And we know this from our Scandinavian colleagues and things like that. We used to think, well, yeah, you reconstruct the ACL, you change the person's life. That's not really very true. And I think the same is true for a lot of stuff we do in the shoulder. But we're trying our best to manage that acute situation at that time. And so I think it's very important when we get the MRI information that we are not able to clearly identify the history or future of what that means, that we don't overread that towards the point that, that patient needs surgery. I think that is false, and I think it leads us to do things that we don't necessarily have to do in some of our athletes. So we really should favor a conservative approach unless we really know it makes a difference.
Like the older patient who's ruptured their Achilles tendon, we can, cast them in plantar flexion. And somehow, someway, by the grace of God, those two ends can find each other. What do you think on the lat? Like, if you just, do you think that would romantic. Be a possibility? And I mean, it just like defies anything that you can wrap your brain around. But I think it highlights this miracle of the body in an attempt to try to heal itself.
I think this was where we get back to, if you do research and you work on animals, what you find is that when you injure an animal, their scar formation is so much more aggressive than the human. So like, for instance, if you do a rotator cuff tear in a sheep, you have to be very careful about assuming that what you did to it actually helped it heal, because they scar in even if you don't put anything in there, and they heal themselves, and they're actually able to get back and be fairly functional. And with humans, we do the same thing when we can. And so the lat, like I mentioned, is outside of the shoulder joint. So I think to some degree, what we've learned from the proximal hamstring injury is probably a closer association to what we should be thinking about than a rotator cuff injury. And that is that it's a tendon outside of the glenohumeral joint. If there's any fibers attached, there seems to be some kind of lattice work or a scaffold for scar tissue to form to be able to share at least a little bit of that load back to the humerus, even if it's not normal. And when you put the arm down by the side, that's the most reduced position of the lat, with the humerus is actually down by the side. If you wanted to keep it separated, you put the arm up in an overhead throwing position. So just by the very nature of how we typically immobilize or restrict motion, we are kind of putting the lat as close to the humerus as we can. It stays in the normal plane that it belongs. And if there's any part of it's attached, it's going to scar back through that area where that detachment occurred. And the more it's detached, the less likely the human body is going to be capable of accomplishing that task. And so I do believe that that's why we see with these, basically that watershed, the type 2A, 2B, and 3s, why there's a difference in terms of their final outcome and using advanced metrics, which includes workload and amount of pitches and everything else. It's because they don't have the full function of the lat and those athletes. And because of that, they probably have subconsciously less ability to decelerate the arm efficiently. So they get tired. They don't throw as hard. They're more nervous about trying to throw at their top velocity because they don't want to hurt themselves again. And also because they don't have the decelerators working at the same level. Mm-hmm. And we're talking literally the difference is 2 to 3 miles per hour. But as you know, if you're a 93 mile an hour pitcher, you can be very effective. But if you now come back and you don't throw 90, you're done.
Yeah.
That you have to have a minimum of 10 miles per hour difference between your changeup and your fastball. And that may even be more with some of the selected pitchers. It is more with some of the advanced hitters we have now. But if you start getting close to 90, even if you threw close to the mid 90s before, it may just be a few miles per hour different. You're going to be done unless you can somehow bring out the Greg Maddux in you and learn how to throw every pitch in the world and outsmart your batters on every single pitch, because that's what you have to do, because you can't overpower them anymore.
When you're an expert amongst experts like you are, is it awkward? So when people are coming to you for like a second or third opinion, and your buddies in New York or your buddies and you have to maybe form a different opinion than what maybe one of you, because you've been president of all these different organizations. Does it ever get a little bit awkward? Like if you have a differing opinion than your buddy with one of these other 30 teams, or?
I would say the answer is that it can get awkward. There's a professional way to manage these things. There are discussions that are held offline.
Sure.
And usually you can work through these things. We're all human. We all see things slightly different, and we may interpret things slightly different. If there's a major difference between myself and one of my friends or peers, I usually assume that somehow they didn't review it, or they got the wrong review, or something happened in the communication. And the first thing I do is I will call them and say, hey, this is what I have. And to make it even more simple, I'll take pictures with my phone. It's so easy today. Just take pictures with my phone and send it to them, de-identified, no patient information on there. Said, listen, this is what I saw. This seems to be different than what you saw. And usually I get, oh gosh, Tony, let me look. They get nervous, and
You're calling them out.
I'm calling them out. I said, I'm not trying to call you out. I just want to make sure. I really want to do whatever's best for the patient. And my philosophy has always been that direction. I don't think there's really a reason to ever in our profession to use your level of expertise to leverage or try to impress someone over another one of the people in our profession. I don't think that ends well for most people. Just to give you an example, in this community of Chicago, I from the very beginning wanted to be the revision specialist, whether it was baseball or whatever. And so I would take care of a patient that's had prior surgery, and sometimes the surgery wasn't done very well. And I would get a call. The attorney would say, Dr. Romeo, you've operated on this patient. Do you think that was done before was the standard of care? And I would say, well, sir or ma'am, I am not your expert witness. I'm the treating physician. Mm-hmm. If you want to ask me questions about what I saw and what I did, I'm happy to answer those questions. But if you want to know about standard of care, then you need to hire another physician who's going to look at that community standard of care and what was done and make that determination. My job is to take care of the problem in front of me, and I'm happy to speak to you about that. And I've done that for 30 years, and I know it really disappoints the legal profession sometimes because they call me in as the treating physician, and they want me to give an expert opinion. I refuse to do that, and it's because I feel my role in this community was to help the patient. And I felt that if I was, even in subtle ways throwing someone under the bus, then the word will get out that you can't send it to him because he's going to expose things and you're not going to get, you don't want to do that. And I can tell you that even at the organization I was at before, it has a lot of superstars. It was very clear I received more referrals from other orthopedic surgeons than any one of the others, because they didn't look at me as a threat or a problem. They looked at me as a solution to what they were trying to deal with, whether it was a complex problem or a complication or just some unusual thing. And that was the role that I wanted. And I do the same thing in baseball. I don't want to be part of a process calling people out. My whole goal, in fact, when I was invited to be part of Major League Baseball's research committee, one of the questions I asked, I said, will we be able to publish? And they were like, well, what do you mean? And I said, you guys have published so little. Well, there's a lot of politics. The Players Association has to review these. And I said, I don't want to be part of an organization that has all this data and we're putting out one paper a year. That seems like a waste of time. Well, I think we can change that. We'll work on that. And I said, I'll give it 2 years. And if we can make a difference, I'll see if I want to go along with that. And I wasn't trying to be mean. I just thought we could do it ourselves within our own organization. And I didn't want to work with people that were unwilling to share the data. And it turns out there was a couple of significant roadblocks. One, there was some anxiety on the Players Association of publishing this information. And they had a process that was in place that once we were done with the paper and the manuscript was submitted to them, it could take 6 months to a year before the reviewer said, yeah, it's okay, even though it could have been reviewed in a weekend. So it was just a built-in slowdown process that wasn't necessary. And then the second thing was they were just unwilling to share the data because they were worried that if they shared it with one group more than another group, it might cause some favoritism or things like that. Well, I was able to convince them. I said, listen, I just want to show you what's possible here. Send me 3 sets of data and I'll get you back the manuscripts. And it was probably 3 months or longer. And they did that. They sent them to me and I called in, and you would know these people because they're superstars now on their own, but two of them were residents. One was a partner. And I said, we have these 3 sets of data. I think there's enough to put papers on all these things. Let's see what we can do. And it was like a Wednesday. On Monday morning, we sent Major League Baseball 3 manuscripts. They crapped their pants. They could not believe, oh, how did you do that? I mean, you guys have the statistics in place. You have
they wanted to.
And I said, I wanted to show you that you guys are making this out to be a much more difficult process than it needs to be, and that there are significant restraints in the system that's not allowing us. I want to demystify baseball. I don't want 2 or 3 people to say, I know exactly what to do and you don't, so send me the patients. I want every single doctor that's taking care of a baseball player or an athlete to be armed with the same amount of evidence-based information to say, you have this problem. We know if we do it this way, you're going to have this result. And for the greater than 10 years I've been on that committee, that's always been my emphasis. Why do you want to just give this to a select group of people or only these people? This is data that we need to share so everybody can have an equal ability, not an equal ability to be a great surgeon, an equal ability to take good care of patients. It just refocus it. What's the right thing to do for the athlete? And I think if you just do that in all parts of medicine, you're going to end up with the right answer. People are going to try to make it cloudy and vague and, well, what about this and what about that? And they'll throw all these distractors at you. If in the end, what is the right thing to do for the athlete or the patient is the way you answer it, it'll be the right answer. It just may take time.
It's beautiful. Well, we've taken a lot of your time. We had 2 cameras, backups. They both died. And so...
It's the universe telling us
yeah,
to go big.
I think it's probably time. So I really look forward to talking about things other than the lap, because that's what you've kind of been typecasted. But Dr. Romeo, we just really appreciate the hospitality. Number one, welcoming us to your beautiful home, getting sushi for us. Julie and Adam, just
gluten-free.
Awesome. Yes, gluten-free. Thank you for making this happen. We'd love to maybe do it again and talk about anything but the lap. How about that? So
that would be great.
Anything but.
But I just think, Brett, we've been lucky enough to sit down with the likes of Jimmy Andrews and Thomas Bird, and obviously now, everybody that has been successful in this route of orthopedic surgeon that is changing the world of medicine is not only humble but dedicated to their craft. And I think just from being with you today, I'm thankful for your dedication, number one, and thankful for your willingness to share, because I think that's another thing that's kind of maybe lost a little bit in medicine is the unwillingness to share your experiences and to share your failures and your successes. And so anyway, I just want to thank you, number one, for sitting down with us, and for you two for hooking us up. So,
well, thank you for the opportunity, and I appreciate it. I have had a wonderful career that's been professionally very satisfying, but I can tell you that for me, sort of the greatest reward that I have is when I have the opportunity to influence the quality of care that we give our patients, whether that's being a mentor to someone like Julia, who then goes out and does what she does at such an amazing level. And we know how many people are affected in a positive way because of that, whether it's participating in a research project, whether it's being involved in something like this podcast, just sharing ideals that I think that despite some of the chaos and confusion that's occurring in healthcare, that it almost goes back to the old wallpaper that says you learned everything you need to know in life in kindergarten. It's just the way you take care of people is, I think that if you focus on taking care of people and you make that the centerpiece of the way and the why you do things, in the end, you'll come up with the right answer, and you'll leave the legacy and the professional rewards that you really sought from the very beginning. So for me, that's really important. It's the names you mentioned, like for instance, Dr. Andrews. I used to spend a week with him every other year for almost a decade, and the amount of education information he shared with me beyond the operating room, how to care for patients, how to you can't even encapsulate that, but that's why everybody that's ever worked with him has just such tremendous respect for him. And I feel that that's part of what my position is in life now, is to continue to pay that forward and to continue to try to lead and have example of the best way to care for people is a way that we all have the opportunity to do. We just have to stay focused on what's the right thing to do for our patients.
It's beautiful. Thank you all. Really appreciate it. Guys, re-listen to this. There's just so much gold in that. So anyway, good luck with patients, and we'll see you next time.
Just the last 2 minutes.
Yeah, the last 2 minutes is worth it. That's right. But anyway, good luck with patients. We'll see you next time, guys. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.